Welcome to Around the Room, a podcast brought to you by the Canadian Rheumatology Association. Attention CRA members, we're excited to share an exclusive opportunity to enhance your clinical documentation with cutting-edge AI technology. The CRA has partnered with top vendors Scribeberry and Heidi Health to bring you an exclusive CRA member discount and a 1-month free trial of their rheumatology-optimized AI scribes. These AI-powered scribes are tailored specifically for rheumatology, helping you achieve high-quality documentation with ease while streamlining your onboarding process. Take advantage of this exclusive CRA member benefit. Start your free trial today. Visit room.ca to learn more. And now to Around the Room.
This case starts with a 42-year-old female who presented to the emergency department with progressive chest pain, shortness of breath, and myalgias. This was very gradual over about 4 to 5 months. After 2 months of having very mild symptoms, she traveled to India to visit friends and family, where her symptoms then progressed.
That's Dr. Alec Yu. He's a rheumatology resident at the University of British Columbia and our guest on this special Medical Mysteries episode of Around the Room. We're recording this in person at the CRA's annual scientific meeting in Calgary. Welcome. I'm Daniel Ennis. I am Watson to my co-host Holmes. Dr. Janet Pope. Welcome, Janet. How are you?
Great, very well. I think we're both Sherlocks.
I'd watch that show for sure. 2 Sherlocks. See how they get along.
There you go.
I'm into it. Okay, so today we're doing our latest installment of a series we really enjoy called Medical Mysteries, where a colleague brings us a challenging medical case they've been involved with, and Janet, primarily, and me as sidekick, try and come up with the diagnosis and kind of model clinical reasoning and go through it all together. So, as I said, Alec Yu is one of our PGY4 residents in rheumatology at the University of British Columbia in Vancouver. He's a brilliant young clinician and has a big heart. He has a particular interest in inner city health. Alec, welcome. How are you enjoying the ASM?
It's been a fantastic conference so far, and long-time listener of this podcast, so it's an honor to be here.
And don't you have a story about that? About the podcast?
Yeah, so when I was an R1 in internal medicine on maybe the first or one of the first Medical Mysteries episodes, it was presented by Dr. Angela Hu and Dr. Danya Al-Nujaydi. I was actually the R1 internal medicine on that team. And Dr. Pope yourself had made this offhand comment that the R1 should consider doing rheumatology. And so 3 years
because
later...
Because of your brilliance. I love it.
Because of your grace, but here I am.
Well, we're very lucky to have you, and thanks for preparing a case for us. It's we love doing these episodes. They're a lot of fun. So maybe we'll hand it over to you to start laying out this mystery for us.
Absolutely. This case starts with a 42-year-old female who presented to the emergency department with progressive chest pain, shortness of breath, and myalgias. This was very gradual over about 4 to 5 months. After 2 months of having very mild symptoms, she traveled to India to visit friends and family, where her symptoms then progressed. She then flew back to Canada, and about 3 weeks after flying back to Vancouver, presented to an emergency department in her community due to worsening symptoms. She was describing sharp chest pain that was non-pleuritic, some shortness of breath on exertion without orthopnea or paroxysmal nocturnal dyspnea, and progressive myalgias worse in the legs than the arms. She had no previous medical history and no medications, including no herbal or supplements. And she was born in Delhi, lived in Canada all of her adult life, and occasionally visits friends and family with no known tuberculosis contacts. She's a non-smoker, no alcohol and no substance use, and she lives with her husband and daughter in a suburb, working as an accountant. Family history-wise, her mother is healthy, her kids are healthy, and her father passed in his mid-50s due to a medication error while hospitalized for a respiratory illness in India. She has no known family history of any autoimmune diseases. In the emergency department, vitals, including a cardiac, respiratory, GI, and neuro exam, were all normal, and she described tenderness to palpation along the bilateral thighs and calves. Her CBC, electrolytes, renal function, and liver enzymes were all normal, and a CRP was borderline elevated at 3.1, with our upper limit of normal being 2.7. Her D-dimer was 2 times the upper limit of normal, and her troponin was 300, with our upper limit of normal being 18. The repeat troponin was stable at pretty much the exact same number, and a BNP was slightly elevated. Her ECG showed some non-specific T-wave abnormalities, and they went on to get a CT pulmonary angiogram, which showed segmental and subsegmental pulmonary emboli in the right lower lobe. The CT commented that this was a small clot burden with no signs of right heart strain. She was admitted, and a subsequent echocardiogram showed an ejection fraction of 54% with mild regional wall motion abnormalities. Now, I'll pause here. I know it's still very much a general case, but I also know that you're both excellent doctors in addition to excellent rheumatologists. And so if you were seeing this case in the emergency department, what would you be thinking?
What's on your mind? We'll start with you, Janet. What do you think?
Okay, so the shortness of breath, non-pleuritic, so I'm not exactly sure what you mean by that, but sharp and dyspnea, relatively new. She had traveled, but that was like 3 weeks before. But it looks like she's had a PE, and that would go with the BNP. Interestingly, tropes are up. The heart's not too problematic right now, but I don't think you gave us her CK. Just saying.
There was no CK done at this time.
Okay, we just have the tropes.
So you have some tests that are already kind of running through your head that you want to kind of investigate this further. How about this? Do you think that the with the segmental subsegmental PE, you're told that the clot burden isn't huge, and you have an echo that's not showing right heart strain, but does have an abnormality on it, and we don't have her PASP yet. Do you think that this much PE can adequately explain this trope in BNP? You know, without echo findings, but you know, it's
well,
PEs
what
often
if it's
cause
on the way down? What if 3 days before she had right axis deviation that no one picked up? We don't know how long she waited to come in. She was otherwise pretty healthy other than this gradual onset. So I'm open-minded that I want to see the trend of the tropes. I don't think right now there's a cardiomyopathy, but I'm interested.
Totally.
And the BNP is only slightly elevated, so PE, that's compatible with the small subsegmental.
Right. And I guess we don't know if this is a cardiac-specific trope or if this is actually a trope that's actually reflecting a CK rise, which you alluded to already. And even if, you know, cause and effect, right? Like, is the PE the answer to the whole case?
No.
And so right, there's other symptoms here that are of concern, right? Myalgia is not, to my mind, a primary manifestation of PE. So PE may be secondary to some underlying process that links in the myalgias. That's kind of what's on my mind.
And the tenderness on the thighs and calves bilaterally, it's highly unlikely that she has a big clot, say, above that bilaterally.
Yeah.
So iliacs are even higher in the pelvic area or something. And even with that, I'm not convinced that this tenderness is a Homan sign equivalent in the calves, etc. So I'd be very interested in the CK, and I think in a whole myositis panel. And we might have a red herring, but you can be hypercoagulable having if she has some kind of chronic inflammatory myositis. So that's kind of where I'm going right now.
Yeah.
I think it might even be stuff we have to know about at some point.
Oh my God. I
We
sure
can't
hope
rule
not.
out a rheumatic problem this early.
Oh no, I have to do my job. So you said you wanted a CK. I think we're probably going to get an ultrasound of those legs, make sure, like, kind of see
I guess it
what is
depends
this
on what the
tenderness.
exam was really showing. If there wasn't any sort of obvious warmth or swelling, maybe they didn't do it.
Okay.
Because it wouldn't change your anticoag profile right now.
Fair enough. I suppose for me, it would be helpful in answering, why do you have discomfort in the legs and a PE? If we find, oh, you actually have huge clots down the legs, that might be adequate for me to be like, oh, okay, that can give you the leg pain. There's an answer there. So I might go for some Dopplers, probably want a urinalysis, make sure there's not protein and blood
Sure.
in the urine. Also, if she's hypercoagulable because she's peeing out a bunch of protein, that can give you PEs eventually.
And did a spiral CT show anything else going on in the lungs? Anything on
yeah.
like a abnormality that could be a malignancy, things like that.
Okay. So those are preliminary thoughts. Do you mind filling in some of that? Or maybe you tell.
Yeah, you tell
carry
us
on
what
with the case.
happened.
Yeah, you
Yes.
tell us what happened. Those are just our thoughts.
Could you imagine I just gave you guys a case of PE and that was it?
Right. That'd
Anyways.
be kind of, we'd
Yeah.
still be stumped.
Yeah, we'd be like, but what about this weekly positive
Yeah.
OJ
Yes.
antibody? What is that? Okay.
So she is admitted and gets bilateral lower leg Dopplers, which showed no DVTs. And to Dr. Pope's point, the CT chest did not comment on any other parenchymal pathology. Given the elevated troponin and BNP with no signs of large clot burden or right heart strain, cardiology was consulted, and she went on to have a cardiac catheterization. This showed possible type 2 spontaneous coronary artery dissection, or SCAD, in the mid-LAD. And so she started on anticoagulation for the PE and a beta blocker for the SCAD, and discharged with outpatient cardiology and hematology follow-up. And so I'd just like to pause here. Is SCAD a diagnosis on your radar for rheumatic disease?
Not usually, but I mean, you can dissect from, I think, more in kids or Kawasaki's kids, but we can see, as a for instance, this isn't this patient, but Takayasu's can develop branches that are smaller than we would expect, ANCA vasculitis. But no, at this point, I don't think it's the whole answer yet, but I would say that's not something that I would want to look further into the dissection, other than I do kind of want some antibodies, and somebody probably did the CK.
I also like what we kind of find when we get like angio reports is we get, hey, you ask a cardiologist, they're gonna
Right,
say
what do you
it's
think?
SCAD, right? Like, well, there's a dissection, so it's SCAD, and maybe we take a step back and be like, well, I don't know if it's SCAD. You think it's SCAD. I don't know if it's SCAD. We know there's a dissection, or that's what it looks. The lumen looks dissected. Fine. We're gonna have to kind of see if it's just a primary blood vessel problem or if it's part of something more systemic, and then maybe at the end of that workup we may agree that it's idiopathic SCAD as opposed to dissection from all the secondary causes that Janet's mentioned. So we didn't get a CK or a urinalysis just yet. Maybe that comes later.
We did not. That does come later.
All right, cool.
We were preempting it.
All right, yeah, okay.
All
So
right.
that's interesting though, right? That can certainly be an explanation for her chest pain, even though the PE also could have been a partial explanation for the chest pain. So 2 causes for the chest pain. That's interesting. Okay.
Mm-hmm. I think SCAD is also interesting because previously it was thought to maybe, based off of case series, be related to some of our CTDs, since 90% of cases are in women, usually in the 40s. However, a really good prospective study that was published in 2020 in JACC by Kronzer and colleagues showed no association with any autoimmune disease. And so the only associations were FMD and genetic CTDs like Marfan's.
There we go.
And so moving on, 4 months after her initial presentation, she comes to the emergency department again with progressive chest pain, dyspnea, myalgias, and now knee arthralgias. In the interim, she was seen by hematology, and a workup was done for secondary causes of the PE that included negative antiphospholipid antibodies, a negative genetic hypercoagulable workup, a positive ANA at 1 in 160 with a speckled pattern and a negative ENA, negative ANCA, negative hepatitis B and C serologies, negative HIV and syphilis, negative SPEP and serum-free light chains, and a negative fecal occult blood test and mammogram. She was diagnosed as likely travel-associated PE, and her apixaban was stopped at 3 months. In the emergency department, she continued to have a normal CBC renal function and liver enzymes. Troponin was now at 500 from the previous 300, and BNP was still slightly elevated. A repeat CTPE showed no remaining evidence of PE, and a repeat echo was stable with 55% ejection fraction and still some subtle regional wall motion abnormalities. She got a repeat cardiac cath, which was read by an expert in the SCAD condition, and when reviewed, no longer showed any evidence of SCAD. And actually, when the first one was re-reviewed by the expert, the diagnosis was actually overturned. She then got a cardiac MRI, which showed an ejection fraction of 48%, regions of myocardial thinning and scar, and delayed mid-myocardial GAD enhancement, which when reviewed with cardiology and cardioradiology was felt to be most consistent with chronic myocarditis. She was discharged then with high-dose ASA and colchicine for myocarditis. Of note, there was no evidence of pericarditis, as well as some heart failure medications for her LV dysfunction. And she was reviewed by Rheumatology on the basis of her ANA positivity, myocarditis, myalgias, and knee pain, at which time a urinalysis was done, which was bland, and a CK was done, which was just under the upper limit of normal. A CRP was also repeated and was also at the upper limit of normal, but not elevated. Her review of systems, rheumatologic review of systems and examination were otherwise unremarkable.
Whoa. Okay. So there's a turn has happened.
It has. So the SCAD is the skids, right? It's out.
It's out. It's out. SCAD's out. Okay, but that's helpful, right? Like, one, it's interesting that, even within that very narrow branch of cardiology, there's going to be experts who disagree on, like the angiographic findings. That's interesting. Okay, so there's no SCAD. There's features of myocarditis and chronic myocarditis, which is interesting. And the trope is even higher than it was before. There's not a great deal of inflammation that's being demonstrated, though the CRP is slightly elevated. The CK is technically normal, though I suppose we don't know what her baseline is, but upper limit of normal. So myocarditis and PE and a weekly positive
arthralgias,
yeah,
weekly positive boring ANA.
Boring ANA. You're not excited.
Well,
you see wacky ANAs.
We're not excited. I'm not excited about the ANA, but one of my thoughts, but I don't know, because really I think someone has to tell me, does the cardiac MRI look like this, or a PET, would it look like this? Is this sarcoid? Because sarcoid would be chronic. It can hit anybody, so 42-year-old lady. It might explain the myalgias. It might explain the chronic myocarditis, so the tropes being up with it. The PE could have been a red herring, or who knows, if you have inflammation being a bit hypercoagulable. So I would want someone to tell me if they think it looks like sarcoid, because apparently on cardiac MRI, some people that know what they're talking about, not me, say this looks like sarcoid, and I think it's pan muscle in the heart, but I don't even know that for sure.
And they do comment on like the delayed GAD enhancement and such on like in our cardiac sarcoid clinic. Yeah, I think that's a really good thought. I can't say, and I'm sure listeners are gonna roll their eyes at me, I can't say that PE is like high on my list of manifestations of sarcoid. And this person didn't have any pulmonary lymphadenopathy or other features of sarcoid, no ocular involvement, no skin involvement. So you can have cardiac limited sarcoid, or the other manifestations may be subtle, but maybe we need to consider doing some hunting for other organ involvement for sarcoid.
Other organ, and maybe even somebody doing an endocardial biopsy or myocardial biopsy.
Yeah.
I would also really wonder, I'm not convinced that traveling 3 weeks prior, long flight mind you, but 3 weeks prior to that first dyspnea spell, that it is actually a travel-related PE. But you look hard enough, you see little PEs in people, and her shortness of breath might have been, due to the myocarditis. So
yeah.
I agree that the PE thing isn't right now. It's out of our worry domain, I think. But I think I would love a chunk of tissue of that heart if someone was willing to do it.
Yeah, chop that heart right out.
Yeah, just a piece.
Just a piece. A little
okay,
piece. Fine. We'll leave the rest of the heart in. Just at this point, I know this is like a rheumatology podcast, but if you were a consultant on this patient, would your gut instinct, big picture, be that this is a rheumatology problem, a hematology problem, like a coagulopathy of some kind, an infectious problem, a malignancy problem? Like, do you have what's your spidey sense telling you?
Right. So I wonder about the myalgias being related, and I kind of suspect that they are, but not enough that anybody's imaged them or done an EMG beyond making sure there weren't clots in her legs. But I kind of have a suspicion that we need tissue, because the knee jerk right now, if she comes back in, or if the tropes don't go down in the next 2 to 4 weeks, because she's already getting a little bit of ejection fraction compromise, someone's going to want to trigger glucocorticoids, and we want to say, what are we treating?
Totally.
So I think that, so my sense is probably the muscle problems, myalgias, are also related to what the myocarditis causes, but it's just a guess.
Okay. So those are some of our preliminary thoughts. What kind of happened next in her case? Where did things go?
So rheumatology reviewed her and felt that overall there was a very low index suspicion for a connective tissue disease. They did bring up the possibility of cardiac sarcoidosis, and they did also refer her for an EMG, as the repeat CK was still close to the upper limit of normal, but still technically normal. That EMG came back stone cold normal. And just for good measure, the team had also sent off some screening for some metabolic myopathies that can affect both the heart and the muscles, like Pompei's and Gaucher's disease, for blood spot testing. Both of those came back normal. And so 8 months later, she returns to hospital again with progression of the same symptoms. She did not feel any better on her ASA, colchicine, or heart failure medications, and her troponins were now 900 from 500. A repeat CT pulmonary angiogram was negative again, and an echocardiogram showed further reduction in her ejection fraction to 42%. She got a repeat cardiac catheterization, which was clean, and a repeat cardiac MRI continued to show scarring and gadolinium enhancement, but now noticed borderline enlarged hilar and mediastinal lymph nodes. And so she went on to get a PET scan, which showed uptake in the hilar and mediastinal nodes, as well as the LV wall that would be consistent with cardiac sarcoidosis. An endobronchial ultrasound with biopsy of one of the nodes showed non-caseating granulomas.
Bingo.
So I don't know that this is the end of the case,
No.
but at this point, I would say that if it was me and I was on staff and reviewing this case, I would have done and dusted. This sounds like a nasty sarcoid. I think we've reached a treatment threshold. Non-caseating granulomas in the lungs, cardiac involvement. I would do kind of the due diligence that I often do for sarcoid, which would include making sure that I've screened the eyes for asymptomatic disease. And I think this person's had all the other kind of general screening. I'd make sure I do a good skin exam. I'd check out those joints, see how they're doing. I think I would be kind of comfortable at this point starting immune suppression. But what about you? I wonder.
I
if you're
agree,
skeptical.
and I mean, you want the pathologist to say, is there stuff on the differential diagnosis that I might have forgotten about since med school, kind of
Totally,
thing.
yeah.
So I would want to make sure that we're covering off the differential. I mean, we did suspect cardiac sarcoid, and you don't have to have the adenopathy in real time, the same time the rest starts. She certainly needs, like, the initial treatment, I think, for cardiac sarcoid is usually methotrexate and glucocorticoids. I would do a TB skin test, but she is probably not going to be TB. There was no exposure in past, no known exposure, even though she had just traveled to India a while ago. But she predated, before India, she had symptoms. So I don't think that we're going to be looking at other granuloma type stuff. And then, if she doesn't respond to all that stuff, they're going to look at a TNF. So I would want to just make sure with the pathologist, is there anything else on the differential? Because there might be weird infections that I don't think of. I don't know.
Right. Okay. So I think we've met a treatment threshold. It's a pretty good looking diagnosis. I wonder if there's a turn coming.
And we want an abdominal ultrasound for the heck of it. They've capped her like 3
Oh, yeah.
times now. She's had
totally.
a bunch of CT. She had a PET scan. She's had a bunch of radiation. So let's do something easy instead of a pan scan.
Yeah.
Let's just do an abdominal ultrasound in real time and see what her liver's like and
Fair
any
enough.
other lymph nodes in there.
And I think I still, maybe like what's left over in terms of me being skeptical would be, I just don't know if like the PE is like perfectly well explained. If I misunderstood, the PE happened before the long distance travel or just after?
3 weeks after she came back.
I'm not sure about like that. That doesn't strike me as a great risk factor. Maybe I'm wrong. And sarcoid with it's not like her ejection fraction's like 10% and it's all sludgy in the lungs. So I would still be a little bit worried about why those PEs happen. Thankfully, it hasn't been a recurrent issue. But I'd keep that in the back of my head.
Fully resolved despite inadequate treatment for chest pain and for her throat.
Totally.
So
I'd keep that in the back of my head, but I would certainly go ahead with treatment, and I'd be happy to label this as sarcoid at the moment. Alec, back to you. Blow my mind.
So she had her pathology reviewed by respirology as well as the pulmonary pathologist. Stains were done for fungi and TB and other infections that all came back negative. And so in coordination, they started her on prednisone therapy along with ongoing heart failure LV enhancement medications. At the end of the 6th-month taper of prednisone, a repeat PET scan showed there was no longer any enhancement in any of the nodes and the myocardium. However, she did not feel any better. And while on prednisone, she also did not feel any better. A repeat echocardiogram showed an ongoing low ejection fraction in the low 40s, and her troponins were now 1,300 from 900. She is seen again by rheumatology for consideration of a DMARD for sarcoidosis, and repeat investigations and review of systems, including ophthalmologic examination, showed no evidence of eye, skin, or joint involvement. She did get that abdominal ultrasound that showed no evidence of hepatic involvement, and liver enzymes remained normal.
Okay. I know there's a roundsmanship to being on this podcast, so we assume there's more to come. But would you look at this and just say, okay, well, we just need to be more aggressive? Our diagnosis is right. We had the pathology reviewed. Everyone's weighed in. It's a good diagnosis. It's just about intensity. Or would you actually rethink the diagnosis at this point?
I think with the lymphadenopathy that came Hyler, the biopsy being reviewed and negative fungal, because that's the kind of stuff that I would want to make sure they dotted their I's, crossed their T's on that. So they really said this isn't TB or some atypical. This isn't fungal. The lighting up finally on one of the scans along the way was quite compatible with cardiac and Hyler adenopathy with sarcoid. So I would say the problem is this is a young lady and she's heading towards a transplant if we don't get on with stuff. So I would want to say, without feeling better, but not even just not feeling better, objectively she's worsening, we got to turn this off. Mm-hmm. So again, it's interesting because I only see the ones that have failed stuff, so they usually come in on steroids and methotrexate.
Right.
So I thought they started both together, but maybe they don't. So I'd give her methotrexate. I'd probably figure out how, she's an accountant, maybe they can figure out how to get coverage for adalimumab or infliximab.
Yeah.
Because we do have to turn it off. And I'm quite concerned because in just a period, we're a year and a bit out, I think by now, things aren't going well. And she's probably on all the good drugs, your Entresto and her DAPA Flozin thingy and all that stuff. So they know how to treat heart failure and she's not going the right direction.
Yeah, the failure of her, like with good, like even just with the LV enhancing therapies on its own and high doses of prednisone presumably at the beginning.
They should re-demodel. Yes.
No, right. No improvement in ejection fraction I see as a worsening, not just a stability.
Right.
I think that's
a red flag.
That's through treatment. The ejection fraction still low, so that's quite disturbing.
Right.
Yeah, I think I wouldn't have been rethinking the diagnosis. I think I would have just assumed I was not being aggressive enough.
Right.
And I probably would have tried to find a way to get a TNF.
And we would ask about funny things like weight loss. Is there something, I don't think there's something perineoplastic. It'd be pretty darn slow if it was.
Like
but,
lymphomas
right, exactly. Is there something else going on in addition? And I don't think so. And I don't think we see chronic COVID as for instance, doing this. Like long COVID isn't still the active infection for months on end.
Right.
So I really think it is sarcoid and we just have to get on with it. But, sometimes we're wrong.
Totally.
We'll see.
It's so rare, but sometimes
right.
we're wrong.
We've been known to be wrong at least once. Not on the medical mysteries, though.
And I guess just one consideration that would float through my mind about giving TNF to someone with heart failure is that TNFs can worsen heart failure.
Right.
Unless you're right about the diagnosis.
Right.
So I would take a moment and be like, do I have another agent that I could use that has no chance of worsening heart failure? and is broader spectrum. In case I'm wrong about the diagnosis, I'd at least play with that in my head. But I think I'd be happy to proceed with a TNF inhibitor. If her heart failure worsens, then I was probably wrong about the diagnosis. And well, now we move on to more aggressive investigations, maybe. Okay. What do you folks do?
So after being admitted, she was seen by a very astute cardiologist. And after hearing that her father had passed of a medication interaction in India in his mid-50s, she was encouraged to reach out and ask her mother for more details around this. And apparently the information that was passed back was that this was an interaction between an over-the-counter cough and cold medicine and an antibiotic, which just sounded really fishy. She was then encouraged to ask in her extended family for their extended family history, and it turns out that 2 of her cousins informed her that they had had ICD implantations in their 30s and 40s for genetic cardiomyopathy in a gene that codes for cardiac troponin. A whole exome sequencing study was done for her, and she tested positive for the same pathogenic gene troponin variant known to cause a variety of cardiomyopathies. She underwent ICD implantation and cardiac rehab and is followed peripherally by the cardiac transplant clinic with the expectation of possible future need for transplantation.
What? Okay.
Okay, so the biopsy is mimicking 100% sarcoid. She gets lymphadenopathy. It seems so strange. Did cardiac sarcoid tip her over? No, because the tropes predated any lighting up of her mediastinum. And of course, I've never heard of this in my life, so it's not even like some weird cardiomyopathy that we've heard of.
Right. Now, I'm curious kind of what, first of all, that is just good history taking, right? That had nothing to do with fancy investigations. You told us up front, family history, there was an unusual death. And of course, someone coming in, like your med student, if they said, they had a family member die young, mysterious circumstances, you'd be like, what was that? Can you elaborate? What mysterious circumstances? So that's just good history taking on the cardiologist part that costed the system no money, and found out that there's a broader family history. That's very interesting. I think if we had known that, oh yes, a bunch of my family members have very unusual arrhythmias or heart disease, we'd be like, well, that's important. But I'm not sure I understand the link just yet with the granulomas. So was there a theory behind that? Is that something seen in the disorder?
It's a great question. And so they've actually done a number of large retrospective analyses of cardiac sarcoidosis, and especially when it's isolated cardiac sarcoid, which was not in this case. When genetic testing is done post hoc on all of the cohorts of isolated cardiac sarcoid, pathogenic variants for cardiomyopathy are actually seen in between 21 and 36% of cases. And so a lot of these isolated cases are likely misdiagnosed sarcoid. However, there are a handful of case reports of both biopsy-proven extracardiac sarcoid and a pathogenic variant causing a cardiomyopathy, with some of these authors hypothesizing that these genetic cardiomyopathies create these localized immunologic or inflammatory changes that actually predispose patients to the pathophysiology of diseases like sarcoidosis. And so in this specific case, given that she had biopsy-proven extracardiac sarcoid that seemed to improve after sarcoid therapy in terms of the myocardial enhancement, we favored the very rare co-occurrence of both sarcoidosis and a pathogenic genetic variant, of which that cardiomyopathy was driving most of her symptoms, we believe.
Okay, I was pretty stumped. So there's a couple things that might make sense here to put it together. So again, I don't know pediatric rheumatology very much, but you can have congenital sarcoid, so kids, and I think it's the NOD pathway. And I don't know that this pathway with the exome sequencing being abnormal. I guess it makes sense that you can have sarcoidosis, that's a genetic perturbation or a mimic-ish of sarcoidosis, and a different kind of variant that could give you cardiomyopathy. And you could say, well, if I treated her for cardiac sarcoid, she would have gotten the ICD, she would have gotten the heart failure treatment, I would have given her a lot of immune suppression, which she probably would have potentially gotten anyway, and she would have ended up possibly being watched for the need for a transplant. The main reason that you'd want to make the right full inclusive diagnosis, she's got a kid, and she might have siblings, etc., even first cousins from some of these other family members more distant who have the ICDs, and maybe dad indeed had it. So you'd want to know, because there could be potential screening, and if the CK goes up, watching any of these family members more closely. I think it's totally bizarre. I think the fact of having cardiac sarcoid, which we kind of came up early with that, cardiac sarcoid and some weird gene variant, sky's the limit. It's a new one to me.
That's really bizarre. And I don't want to take us back too far. The PET scan showed improvement in the cardiac, like the delayed GAD enhancement.
Mm-hmm. It was gone on repeat.
So there was true response. There was metabolic response to our treatments. And I think that's a very interesting solve. And I think that ultimately makes sense to me. I'm not sure that I fully understand the link between obviously the genetic disease and the granulomatous disease, but it really does sound like this person has both, associated or not. Alec, thank you. That's a really fantastic case. And Jenna, you're right. We may have ended up in some of the same treatment places.
Right. I think knowing, because of the family members, that this is where you would like to get something that can be screened for, watched for carefully, etc.
Totally.
I don't know where the myalgias come in. If she had normal EMGs, who knows? Right?
That was nothing.
Right. Well, it was probably
maybe,
something, right?
It
was her
it's a component.
subclinical occult sarcoid that was elsewhere before she even lit up in her hilar adenopathy area. So who knows? Very, very good case.
Thank you. And just to wrap things up, I wanted to mention that this patient finally arrived at a diagnosis after a long 2-year diagnostic journey that had significant impact on her function, her family, her mental health. And I think that her case serves as an important reminder to avoid search-satisfying bias, to avoid anchoring on a diagnosis just because an imaging test or an expert tells you that that's the truth, while they may not be seeing the entire picture. I'd like to thank the patient for being willing to share her anonymized story for us to learn from, and also my supervisor, who is one of the best clinicians and scientists that I've ever met, who's a good friend of yours, Dr. Thomas Roston, who ultimately made the diagnosis.
Great. Well, Alec, thank you so much for coming on the podcast. We really appreciate it.
And that's a pod.
That's it for this episode of Around the Room, recorded in person at the CRA Annual Scientific Meeting in Calgary, Alberta. For questions, comments, and future episode ideas, email us at info@room.ca or tag us on social media. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. And of course, an extra special thanks to Dr. Alec Yu and Dr. Janet Pope. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and write a review wherever you listen. It helps people find these interviews. Be sure to subscribe so you don't miss future episodes. Until next time, I'm Daniel Ennis. Thanks so much for listening.